Hi there, my name's Associate Professor Andrew Martin. I'm a biostatistician working at the NHMRC Clinical Trial Centre at the University of Sydney in Australia. And over the next 40 minutes or so, I'm going to be giving you a bit of an introductory talk on a number of topics that you see on the screen here. And I'm going to talk about these topics mainly in the context of a classic two-arm randomized controlled trial design. However, these concepts have broad applicability to clinical research in general. So what are these particular topics? Well, these are the ones I've been asked to talk to you about. Hypothesis testing. We'll look at some common analysis approaches for different types of data, different types of endpoints. We'll look at the issue of multiplicity and the multiple comparisons problem in clinical research. And we'll drill down and look at a particular source of multiplicity in trials research, and that is subgroup analysis. So let's begin by thinking about the process of undertaking a clinical trial where we are interested in evaluating the effect of an intervention on a particular endpoint. And we can categorize endpoints in various ways. Is it an endpoint that lies on a continuum? For example, waist circumference, BMI, systolic blood pressure. Is it an endpoint that is binary in nature? So, for example, being a responder to treatment or not. Perhaps it's a time to event endpoint, one where we're measuring the elapsed time from being randomized in the study up until a particular event occurring, like time taken to eradicate symptoms or survival time. And one of the important features of time to event data is that it may be that we have some individuals in our data set that are never observed to see the event in question. So if it's survival time, for example, then there may well be some individuals in our study that are still alive at the time that the final analysis is undertaken. So they do not have a perfectly defined survival duration because their observation time is in fact censored at that point of analysis. Anyway, we'll come back to these different endpoint types, continuous, binary, and time to event, when we look at some common analysis strategies. Statisticians would consider a trial endpoint to be a random variable. So what is a random variable? Well, it's the result of a chance event that can be measured or counted. The outcome of one of these chance events, so what pain or intensity an individual patient will experience, can't be predicted perfectly, but we can build up a distribution if we observe enough endpoint data from enough participants in our study. So let's start with something really simple to kind of go through this process. And we'll begin with the outcome of tossing a coin. So if we toss a coin, it might land heads side up, it might land tail side up. And we'll progress through these examples to ones that have greater clinical research relevance. So here's an example of a distribution we could build up by getting enough replicated information or repetitions of a coin toss. And you can see a histogram here where after performing many tosses of the coin, we're obtaining 50% of the time a heads and 50% of the time are tails. So, although we can't predict with certainty what way an individual coin will land, we can discern a distribution. Now, what about another type of random variable? This time it's the sum of two dice. So we roll a pair of dice and we sum the result. And what you can see is the distribution of that random variable having rolled a dice many, many, many times, a pair of dice many, many, many times. And you can see that, a score of 6 is the more likely result of rolling a pair of dice, but we could obtain a sum of 2. We could obtain a sum of 12. Now let's move from those kind of simple examples of random variables to something a little bit more clinically relevant. And here we're looking at hypothetical data that is meant to reflect the distribution of pain scores we might see were we to assess pain in the entire target population of interest, in this case, cancer patients with painful bone metastases. And obviously we can never actually do this for real. We can't measure pain intensity amongst an entire target population. But so these are hypothetical data. And having characterized this distribution, we can also pluck out or further summarize the information here using the statistics like the mean. So the average score in the population is 5 for these hypothetical data. And we can also use another statistic to reflect how spread out the distribution of pain scores is. And so we're seeing a standard deviation statistic appearing on the slide here. All right, now I've said that we'll never be able to obtain measurements from the entire target population of interest. So how do we find out information from that group? Well, we draw a sample, a representative sample from that target population when doing our clinical trial, when doing our clinical study. We make some measurements on the sample, and we then, on the basis of what's been observed, make some inferences back to the entire population. So let's go through this process now with our hypothetical scenario where we've got an entire population's worth of pain data, and we're going to draw a random sample from that target population of size 64, and we're going to look at the distribution of the pain scores we obtain from that sample of 64, and there they are. There's that distribution. It doesn't look as beautifully symmetric because there's much fewer observations here in this sample than in the entire population. So a little bit of lumpiness like this is to be expected. And we can furthermore determine the mean of our sampled scores. And here it is for this particular sample, it's 5.1. Now, if I was to perform multiple draws of samples from that population and calculate a sample mean, you would see sample means that were close to the true mean, but they are sort of jittering about that true mean. And if we obtained 1,000 of these samples and plotted the distribution of those sample means, we start to see something very symmetric indeed. So what's that telling us? It's telling us that the sample mean is an unbiased estimator of the population mean. So what is the purpose of me going through those steps with you? It's to explain how we learn information about the population from a sample, and how statistics that we calculate from a sample can tell us something about an endpoint for an entire population. And this is really an introduction to one of the key topics I'm to cover in this talk, statistical hypothesis testing. So let's move a little bit deeper into this topic by introducing a fictitious randomized control trial, one where we are allocating consenting and eligible patients with painful bone metastases to either receive a placebo in addition to best supportive care, or a fictitious synthetic steroid that we're calling dexamethasone. And we're going to measure pain intensity as the endpoint for this trial using a rating scale. And when talking about hypothesis testing, we need to introduce the concept of the null hypothesis. So this is a statement that reflects a situation where there is no effect going on. The effect of relevance in this example is the effect of our experimental treatment, dexamethasone. So how would we express a null hypothesis for our example? Well, it would be that we wouldn't expect that the placebo and the dexamethasone group to differ in relation to the pain that they experience. We've seen the mean as being a way of summarizing endpoint data that's of relevance for continuous endpoints. So let's express our null hypothesis in terms of the true mean in the two groups is expected to be equal under the null hypothesis. Or in other words, the difference of the true means in the two groups should be 0. So let's imagine we have the entire hypothetical population of interest treated with dexamethasone, and we've got their pain scores having been treated with dexamethasone. We've also, this is somewhat counterfactual, got the same population, but this time treated with placebo, and we've got the distribution of their pain scores. Under the null hypothesis, what the null hypothesis means is that there would be no difference between the true mean in these two groups. So we've got a mean of 5 on the left as being the truth for dexamethasone. We've got a mean of 5 on the right as being the truth for placebo. So the difference between the two groups' sample means should be around 0. So here is a simulation I've performed where I have drawn a group of size 64 from the two conditions, and I've calculated the sample means each time and the difference in the sample means, and this is a histogram of those sample mean differences. So there's 1,000 there, all generated under the null hypothesis, no difference between the treatment groups. And what you can see is that usually we're obtaining sample mean differences of close to 0, but sometimes we can see differences of a clinically appreciable size. For any particular null hypothesis, there is a corresponding test statistic that can be used to quantify the evidence against the null hypothesis. And under the null hypothesis, that particular test statistic has a known distribution, and for continuous endpoints and a comparison between two groups on two means, the t statistic would be the relevant test statistic, and there's a formula there which I'll unpack just a little bit. You can see that the t statistic is a function of the difference in the sample means that are observed, as well as some information about the precision of the estimate of each of those sample means. And the precision of the estimate is related to how big the groups are, how many participants in each of the groups, as well as the standard deviation of the endpoint, so how spread out pain scores typically are. Now, you don't need to remember all of this stuff. What you do need to remember is that for any endpoint, under the null hypothesis, we can characterize the distribution, the expected distribution of an appropriate test statistic. And so here is the t statistic for 1,000 simulated randomized controlled trials, all done under the null hypothesis. And these trials have 64 patients in each arm, so their total sample size is 128. And you can see that the t statistic is generally around 0, but it can be appreciably higher or lower. And however, it's kind of unusual to get a t statistic of greater than 2 or smaller than -2. So that was some empirical data generated by a simulation, but we can use statistical theory to actually characterize the expected distribution of a t statistic under the null hypothesis. And we can look at different cut points for this statistic, and we can quantify the probability of obtaining a result more extreme than that particular cut point. So here, the absolute value of the t statistic is going to be 2 or more under the null hypothesis, only about 5% of the time. Okay, so now we're in the heart of hypothesis testing territory. What we do is we set a threshold a priori for evaluating the extremeness of a test statistic. And that particular threshold, if it's surpassed, we conclude that the result is not very consistent with the null hypothesis. So, you know, we might get a result as extreme as what we've observed under the null, but it's not very likely. And if we've surpassed our predefined threshold, then we would end up concluding that the null is not a good explanation, and we'd reject the null, and we'd conclude, therefore, that there is something going on, there is some kind of effect. Now, for not particularly good reasons, there is a convention for choosing the critical value of a test statistic that corresponds to this 5% region. And what that means is that if we do an analysis, and which we will do later in this presentation, and we obtain a p-value that is less than 5%, then we reject the null hypothesis. Let's go on and apply these hypothesis testing ideas to some analyses now. And we're going to look at an analysis of a continuous endpoint using a t-test, an analysis of a binary endpoint using a chi-squared test, and an analysis of a time to event endpoint using a log rank test. So each one of these tests gives rise to a test statistic, and we evaluate the p-value associated with the test statistic, and we reject the null if we get a small p-value, one that's below our predefined threshold, one that corresponds to an extreme value of the test statistic. And so to do all of this, we're going to be using some software, or at least I'm going to be using the software. And the software I'm using is free. It's available for download. It's called R, and more recently there is a R Studio kind of overlay that makes R nicer to use. I've got some kind of links in this slide to some getting started in R material, as well as some information on simple analysis techniques in R. Having got R started up on our machine and properly installed, before launching into a given analysis, we need to have the relevant R packages loaded, and these are the packages that I'll be using in the demo. All right, let's begin with the analysis of the continuous endpoint. Let's think of them as pain scores. And I'm generating these data because I don't have a data set handy. And what I'm generating is a bunch of scores for a notional control group of 100 patients, and some scores for an intervention group, an experimental intervention group comprising 100 individuals. So I've got that data now. And now I'm going to visualize the data and describe it. A box plot is a nice way of visualizing continuous data and looking at two groups. And you can see this appears to be a systematic difference, with the scores in the experimental group appearing to be systematically lower than the scores in the control group. Let's calculate some other statistics based on those data. We can see the mean in the control group is 4.7, whereas the mean in the experimental group is 4.0. So it's suggesting that there is a benefit favouring the experimental group, so less pain. Well, let's do our t-test now, and we've got our test statistic, or our test statistic 2.3. The software is calculating the probability of observing a test statistic at least as extreme as that under the null hypothesis. We get a p-value of 0.02. That falls below our 5% level of our 5% threshold, so we're going to reject the null hypothesis and conclude there really is an effect here. Okay, let's move on to the example where we're doing an analysis of a binary endpoint. And let's imagine the binary endpoint relates to treatment success. And I'm just generating some data here where we've got a control group of size 100 and an experimental group of size 100. We can then describe what's being observed, and we're seeing in the control group we've got 69 of the 100 experiencing treatment success, and in the experimental group 89 of the 100. And we could summarize these differences in treatment success rates using a difference in proportions or some relative measure of effect like an odds ratio or a relative risk. Then we're going to go in and do our hypothesis test, and this time the relevant test statistic is the chi-squared statistic, and that's giving us a value that you see here highlighted on the screen, and the p-value corresponding to that. So the probability of getting a chi-squared statistic that size or larger under the null hypothesis that there's no difference between the two groups is pretty small, 0.0005. So we would reject the null hypothesis. We would conclude that there's something going on here. Let's move on now to the time to event data. And this time I'm not making up the data because the R software and the package that I've loaded in previously actually has a little sample data set called ovarian, and that data set comprises data on, I think it's 26 individuals, 13 in a control arm, 13 in an experimental arm, and we've got a column, this particular column, oops, I'm just trying to highlight, which is showing the survival time observed, and there's a censoring indicator variable that is saying at that observation time the patient was had died, so that's their death date, or in which case the censoring variable would be a 1, or it's the date that they were, the time that they were last observed not to have died, and the censoring variable will be a 0. So for time to event data, there's two components to the endpoint. There's the time that's elapsed, and then a censoring indicator where 1 is conventionally used to indicate that an event of interest has occurred, and 0 to indicate that the event has not been observed to occur. We've also got in the data set a treatment group which is coded 1 or 2, 1 for control, 2 for intervention. So we can begin by describing the data, and we can see that yes, there are 13 in each group, that there are 7 deaths in group 1, 5 deaths in group 2. We can go on and describe the survival data visually using something called a Kaplan-Meier curve, which you will have encountered in your oncology studies. And you can see the blue line is showing the survival curve for group 2, the red line for group 1. And just to spend a moment interpreting these, we've got survival probability on the vertical axis, so it's 100% initially. We've got time running along the horizontal axis, and you can see that over time, the probability of survival is decreasing. Now, these little crosses, they indicate censored observations. They don't have any effect on, in terms of introducing a step in the curve. An event does introduce a step, so each one of these steps reflects times where at least one event, one death has occurred, and these crosses, you can see are the censored observations. They're not leading to a step, but they are leading to a change in the number left in the risk set for calculating the magnitude of subsequent steps. It looks as if, the survival distribution for group 2 might be a bit better for group 1. We can go on and do our hypothesis test. In this case, it's a log rank statistic, and we are basically comparing the distribution of the events across the 2 arms and looking at what would be expected under the null hypothesis of no effect versus what was actually observed. And so, these O's and E's here in the output relate to the observed versus the expected. We've got our test statistic here of 1.1 and a corresponding p-value of 0.3. So that test statistic is not particularly extreme. Under the null hypothesis, you'd expect to see a test statistic of that magnitude or less, with 0.3 probability. So this is a scenario where we would not reject the null hypothesis, and we would conclude that there's no evidence of a treatment effect here. We've had an introduction to hypothesis testing. We've calculated a few p-values now. Let's move on to talk about the multiple comparisons problem. Under the null hypothesis, the more p-values you generate, the more likely it is that you will observe by chance alone a small p-value. and you will incorrectly reject the null hypothesis. That's known as a type 1 error. And this little table on the right, it shows that the probability of obtaining at least one p-value below our 5% threshold, given, 1, 2, 3, 5, 10, or 25 independent tests being performed. And you can see that by the time you've got 5 p-values to interpret, you've got a fairly substantial probability that chance alone could make one of those p-values, one of those 5 p-values, appear less than 5%. So in that case, we've got an appreciable risk of declaring one of those analyses statistically significant, and that would be a type 1 error. So how is it we can end up with multiple p-values in a clinical trial or in clinical research in general? Well, it may be that we've got multiple analysis approaches, so different ways of analysing the same data set, so techniques that give rise to slightly different p-values when applied to the same data set. It may be that we've got a study where we have multiple endpoints, and so we're making comparisons between the two groups on different endpoints. We might have measured the same endpoint repeatedly over time, and we're comparing the two groups on a number of different time points. It may not be a two-arm study, it might be a multi-arm study, and so there's multiple paired comparisons that can be performed, and that'll inflate the number of hypothesis tests undertaken. It might be that we're looking at the data in a group sequential fashion and performing interim analyses as the data accumulate over the course of a clinical trial. Or it could be that we've got multiple subgroups of interest and we're doing multiple subgroup analyses. And that's the topic I want to move on to in a moment. Having introduced the multiple comparisons problem and have warned you of the dangers of just undertaking hypothesis tests in an uncontrolled fashion, the more you do, the more difficult it is to actually ascribe a clear meaning to the individual p-values produced. The key message I would give you at this point is to very clearly pre-specify what your primary endpoint and primary analysis of that endpoint is for any study that you undertake, and the p-value associated with that particular pre-specified analysis becomes very straightforward to interpret because it's just one analysis. And then all of the other analyses that may be of interest for a clinical study would be considered as secondary to that primary analysis. So yes, we're still faced with a multiple comparisons problem for these secondary analyses, but our primary analysis is uncomplicated because we have pre-specified what that is. So let's now talk more about subgroup analyses. It was one of the topics on the list I was asked to cover. And this is really a line of inquiry where we're wanting to determine if the benefits or harms of an intervention are consistent across patients with different characteristics. So is the effect of the treatment the same for old people and young people, for men, for women, for those with high tumour burden and those with low tumour burden. And another kind of related question is there a particular biomarker that predicts response to our experimental treatment, in which case that would allow us to tailor treatment recommendations on the basis of the particular characteristics of an individual patient. So you could think, HER2 overexpression and Herceptin in the context of breast cancer, let's say. That would be an example there. Now, subgroup analyses obviously have an important role to play in clinical trials research, but they are at risk of leading investigators astray if they're not undertaken methodically and correctly. So some of the guiding principles are on this slide, and they include that the set of subgroup analyses should be limited to a small number of biologically plausible questions, and these are all pre-specified, written into the protocol. They should be conducted using the appropriate statistical tests, and this is a test of interaction or a test of effect modification. I'll give an illustration of that kind of thing on the next slide. We should fully report all of the subgroup analyses that are undertaken so the reader can appraise any interesting result in full context. So if we've done 20 subgroup analyses, which is too large a number, we should not do that, but we should fully report all that's been done so any particular interesting p-value can be interpreted in the proper context, as I indicate on that on this particular bullet point. So let's now see an example of an appropriately conducted set of subgroup analyses, and these come from a trial evaluating a novel potent anti-androgen versus conventional non-steroidal anti-androgens in men with advanced prostate cancer. And this trial, the ENZAMET trial, showed that the hazard of death was appreciably reduced with enzalutamide treatment. And we're seeing that result way at the top of this forest plot here. It's, it's being expressed as a hazard ratio, so you can think about it as the ratio of the death rate in the two arms, and you can see that that is being slowed down by enzalutamide. The rate in the enzalutamide arm is only 0.67 that of the control arm. And now you can see the full trial cohort split into various subgroups. So let's pick on this first one here, volume of disease. So we've got individuals categorized as having low volume of disease or high volume of the disease. And you can see a hazard ratio for those in the low volume of disease subset and a hazard ratio for those in the high volume of disease subset. The test of interaction, the appropriate test for the subgroup analysis, is whether these two hazard ratios, whether the observed difference between those two hazard ratios is consistent with the play of chance or not. And so it's not the individual p-value associated with the each individual subset, it's the p-value comparing the hazard ratios across the two subsets that's of interest. And that's what we've got over here, the p-value for interaction. Whoops, I'm circling the wrong one. There it is. The p-value for interaction, 0.04. Now that's interesting, right? That's interesting because that is below the conventional 5% threshold for declaring statistical significance. But look in the last column, we've got something that's a little cryptically described as the adjusted p-value. This is a statistical technique for adjusting the individual p-values for the multiple tests that have been performed. Okay, so this is addressing the multiple comparisons problem. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 tests of interaction being performed. And you can see prior to adjustment, some of them fall below the conventional criteria for declaring statistical significance, but after adjustment, none do. So this is a nice example because it illustrates the appropriate way of performing a subgroup analysis in terms of a test of interaction, and it also shows an approach for appropriately dealing with the multiplicity that arises having performed a whole bunch of tests of interaction. Let's wrap up. What have we covered? Well, we've looked at hypothesis testing. We've learned about test statistics and p-values and how these are used to reject a null hypothesis. We've applied those ideas to the analysis of some data. We've looked at an analysis of binary endpoint data, continuous endpoint data, and time to event endpoint data. We've been introduced to the problem of multiplicity and how that needs to be borne in mind when interpreting p-values from a study, and the importance of pre-specifying what the primary analysis of the primary endpoint is to protect that analysis from the complexities that arise from multiplicity. And then we've drilled down a little more to talk about subgroup analyses